Case Study Number 1, Part 2.
These are Client J's targeted occupational performance areas in more detail. This is the level of cognitive functioning that Client J is currently at in more detail.
Our current goal is to get Client J to level 7, which is automatic appropriate. Person goes through daily routine with minimal confusion. More detail can be seen here.
The assessments that will be used with Client J include the Brain Injury Visual Assessment Battery for Adults, which is just a basic visual screen, the Agitated Behavioral Scale, which is takes a measurement of agitation, the Modified Ashworth Scale, which measures spasticity and tone. We'll take goniometer measurements to measure her range of motion. We're going to do manual muscle testing to measure her strength. We're going to be doing the executive functioning performance test, and that will measure her cognition and her performance of IADL. We're going to be using participation objective, participation subjective, just to measure her social participation. And we'll be using the home and community environment instrument to measure her home environment and how she's engaging in her home for safety. The Brain Injury Visual Assessment Battery for Adults is a screening assessment for visual processing abilities. It includes 17 subtests. Some of the functional limitations associated with visual impairment include a person's ability to complete ADLs, read, write, drive, and functional mobility in navigating environments safely.
The Agitated Behavior Scale is a measure of agitation that can be used to measure changes in agitation level over time. The total score reflects overall agitation, with subscales specific to disinhibition, aggression, and lability. There's 14 items rated on a scale from 1 to 4, and scores indicate within normal limits, mild agitation, moderate agitation, or severe agitation.
The Modified Ashworth Scale measures muscle tone or grade spasticity. TBI patients typically present with an increased resistance to passive elongation, also known as hypertonia. This increase in spasticity can contribute to abnormal positioning of limbs, which causes secondary changes in the mechanical factors.
Goniometer measurements assesses range of motion at a particular joint. Joint range of motion contributes to the client's motor skills required to participate in occupational activities. The occupational therapist will first do a functional screen of the upper extremity and document whether the joint is within functional limits. A formal goniometer measurement will be taken on Client J's upper extremity joints that are not within functional limits.
Manual muscle testing, or MMT, assesses muscle strength, which is the power of a muscle to resist movement. Muscular strength is an important client factor to assess in determining potential function. MMT is graded on a scale from 0 to 5. The therapist will first do a gross screen of strength of the major muscle groups in the upper extremity. Muscle groups scoring 4 or below will be reviewed and will be the target of intervention strategies. The strength screen can be performed while doing a range of motion screen.
Executive Functioning Performance Test, also known as EFPT, assesses cognitive deficits as well as IADL performance. It focuses on what a client can do. 3 objectives that it entails includes assesses client's executive function, identify their functional capacity, and identifies level of assistance needed to complete tasks while participating in occupational tasks. It consists of 32 items and an initial hand washing task. It's scored based on the following criteria: initiation, organization, sequencing, judgment and safety, and task completion.
The Participation Objective, Participation Subjective Assessment, otherwise known as POP, is an assessment of the individual disability in a normative outsider's perspective of participation in ADLs, IADLs, and community integration. It is a 26-item measure of participation in 5 categories of domestic life, major life activities, transportation, interpersonal interactions and relationships, and community, recreational, and civic life. From each item, the person is asked about their level of participation, their satisfaction with that level of participation, and how important that particular activity is to satisfaction with life. The objective and subjective responses contribute to a total score.
The Home and Community Environment Instrument assesses barriers in the home and community. It has 6 domains, including home mobility, community mobility, basic mobility devices, communication devices, transportation factors, and attitudes. Each section has its own scoring criteria.
For client J, we will be using the multi-context treatment frame of reference. This approach is used with clients who have neurological disorders that involve cognition, psychosocial, and/or perceptual dysfunction. Some of their objectives include to restore cognitive and/or perceptual abilities to engage in occupational activity, to adapt the activity or environment to allow the client to participate in meaningful occupations, to facilitate transfer of learning across a variety of contexts, and to develop self-awareness to utilize strategies to promote function and decrease barriers. The OT intervention approaches we will be using with client J include to establish and restore, to modify, and to maintain.
Performance skills affecting client J include cognitive skills, motor and praxis skills, and emotional regulation skills. Due to the effects of TBI on cognitive function, the client experiences difficulties with cognitive and process performance skills, leading to slower reaction time and slower processing. The client demonstrates declines in motor and praxis performance skills, specifically with skills related to coordination and balance. She also shows difficulty anticipating changes and adjusting her posture because only the right side of her body has been noticeably affected. Client is demonstrating agitation, especially around unfamiliar people and in unfamiliar environments. She has a low frustration threshold while completing activities such as ADLs. Client J has been experiencing changes in her performance patterns, including her habits, routines, and roles. She is unable to carry out behaviors that she automatically did prior to her diagnosis due to impaired cognition and decreased function in her right upper extremity. Some behaviors she habitually performed that helped her to function on a daily basis are absent, which further hinder her occupational performance. Her normative routines cannot be followed in the same way as they were prior to her TBI due to her hospitalization. Many of her routines have to be modified so they are simpler and so that she can follow them because she is experiencing difficulties with memory, sequencing of tasks and activities, and attention. Client J is currently experiencing role disruption because she is in inpatient rehabilitation. Her roles as a wife, mother, volunteer, and homemaker have been disrupted due to her accident, brain injury, and subsequent hospitalization. She is experiencing role reversal as her husband and children are now taking on more of a caregiver role as she recovers. Her roles as a volunteer and homemaker may need to be reconstructed to maintain her occupational identity.
Some of the client factors that are causing client J problems include her strength, her range of motion, her endurance, and her mental functions. Due to her motor vehicle accident and TBI, she currently presents with decreased strength and function in her right upper extremity and decreased strength in her right lower extremity. She is experiencing increased tone throughout her right upper extremity, thereby limiting her range of motion. She experiences pain in her shoulder and wrist with passive range of motion. Her endurance level is lowered due to her right neglect and reliance on her left side, which leads to fatigue. She completes interventions and activities as tolerated physically. Her agitation indicates a decrease in her emotional stability. The client is demonstrating issues with impulse control, which affects her safety. Other mental functions that pose an issue are her decrease in intention, memory, problem-solving skills, and executive function. With regard to client J's personal context, she is a 55-year-old woman who is a homemaker, volunteer, mother, and wife. She is financially stable. However, she is experiencing role disruptions due to her hospitalization. With regard to her social context, her husband and 2 grown children are available to help her adjust to her condition. She has relationships with the people at the hospital she volunteers at and has a small network of close friends. However, her agitation and decreased cognition affects her social participation. With regards to her physical context, she lives in a 2-story home with stairs that lead into her home, which may pose a safety risk because she requires assistance with transfers and is demonstrating decreased safety awareness and impulsivity. The long-term goals for client J are for her to complete grooming, upper body dressing, and bathing activities with minimum assistance, to increase her functional mobility and complete transfers with minimum assistance, and to increase her cognitive level to Rancho Level 7. There are 3 short-term goals listed under each long-term goal, which are in place to provide structure for her to achieve her overall occupational therapy goals.
Here is an overview of client J's occupational therapy treatment plan, which has been discussed throughout the past several slides. One of the interventions for client J includes cognitive strategy retraining. Activities such as using planners, memory books, card games, or puzzles may be helpful, using an iPad or computer for Lumosity program training or Sudoku, or electronic visual schedule planner used to establish routines. The multi-context frame of reference addresses reframing and cognitive functions, for example, memory or attention, encourages range of motion in her right upper extremity through the use of meaningful leisure activities, and stimulates primary cognitive domains such as attention, memory, executive functioning, so that natural recovery will be enhanced and accelerated. This intervention can be graded by using a touch screen, such as an iPad, which may be easier for her to use than a mouse with a computer. The number of tasks written in her planner can be increased or decreased. The amount of time for each activity can be extended or decreased, and a family member or friend can push the buttons if the client is unable. Cognitive strategy retraining stimulates primary cognitive domains so that natural recovery will be enhanced and accelerated. There are numerous apps available that may be useful for TBI patients and caregivers. One of these apps is the Lumosity.com brain training. The games on this website have been designed by neuroscientists, and several research studies have demonstrated that it improves working core cognitive ability. A visual schedule planner might be a useful tool for Client J. Pictured here is a completely customizable visual schedule iPad app that's designed to give an individual an audio and visual representation of the events in their day. In addition, events that require more support can be linked to an activity schedule or video clip to help model the task even further.
Another intervention for Client J includes an exercise regimen of her upper extremity, which includes her motor function, strength, range of motion, and balance. Activities include catching and hitting a ball, using the TheraBands at the yellow and green level, and dumbbells for resistive exercises, weight-bearing hand positions and increased range of motion of upper extremity to address increased tone, and massage and heat application to help reduce abnormal tone. According to the multicultural frame of reference, engaging in motor activities that can be performed almost automatically while minimizing demands on weakened cognitive functions, based on frame of reference that encourages motor practice and motor planning using simple steps. In regards to grading, we can increase or decrease to different resistive levels using the TheraBands, increase or decrease dumbbell weight, alter the number of repetitions and sets.
The last intervention for Client J is to work on her activities of daily living. Activities include regaining independence and basic self-care tasks, such as dressing, grooming, and bathing. Also, she can use checklists and cues to complete the activities. According to the multi-context frame of reference, this activity addresses occupational functioning by using real-world tasks. With regards to grading, the client and OT can sequence tasks. The client can perform some of the tasks instead of all of them. The OT can provide verbal and physical cueing, and then the task complexity can be changed as the client improves. Based on the interventions, some of the activity demands of note include the objects and their properties, which includes the equipment and supplies that are required for the intervention activities, the social demands, because the cultural context demands that the client conforms to social rules while playing games with others, and there's also a social expectation for the client to dress and have good basic hygiene. Also sequence and timing, because there are numerous and complex steps that may be challenging for the client to follow given her cognitive decline due to her TBI. Therefore, sustained activity for a prolonged period of time may be difficult due to her lower endurance level. Other activity demands related to the interventions include required actions and performance skills, including her motor practice, cognitive, and emotional regulation skills, required body functions, such as her mental functions, neuromusculoskeletal and movement-related functions, sensory functions, such as vision, pain, and touch. Also, her required body structures, such as structures of the nervous system, skin-related structures, structures for sensory processing, such as her eyes and ears, and movement-related structures, such as her limbs, hands, and muscles.
For the service delivery of the treatment plan, the team members that will be participating, the OT who will screen, evaluate, and reevaluate, the CODA who will carry out interventions designed by the OT, we will co-treat with a speech-language pathologist, and we will co-treat with a physical therapist. The therapy will take place in the gym, which will include the gym exercise regimen, cognitive activities, and other IADLs, and also in the patient's room, where we will complete ADLs and cognitive activities. The therapy will take place in the morning, and we'll complete ADLs and cognitive retraining, and in the afternoon, it will be exercise and cognitive retraining. The frequency that we will meet is 3 hours of therapies per day, 5 times a week, a total of 3 weeks. The focus of Client J's outcomes includes supporting health and participation in life through engagement and occupation. At the conclusion of 3 weeks of inpatient therapy, Client J will be discharged to an adult daycare program.